I think my job is the easiest job. Just I'm presenting a case, and we are listening to your opinion. The main aim is to define those patients exactly, patient with advanced heart failure, and to explore the therapeutic options for them. He's a 52-year-old man, referred to our heart failure clinic as a case of advanced heart failure in July 2014. He's known case of non-ischemic dilated cardiomyopathy for at least 3 years before presenting to us, with ejection fraction 10% and dilated LV. Cath 1 year ago showed normal coronaries, and he had CRTD 6 months ago in the referring center, and he had comorbidities in the form of diabetes mellitus and hypertension. His symptoms included exertional dyspnea and fatigue. He is unable to climb one flight of stairs without dyspnea. He has occasional pain D and orthopnea, NIHA class 3 and 4. He has orthostatic dizziness, and he has lower limb edema bilaterally, ascites, almost up to the level of scrotal edema. I can say anasarca for the last 2 months. In terms of hospitalization, he has twice hospitalization in the past 6 months, mainly for fluid overload, and received IV therapies in both admissions, including IV dobutamine and dopamine. He was declined for cardiac transplantation due to pulmonary hypertension. His current medications we presented to us, he was on furosemide 80 milligram PID, metolazone 2.5 milligram twice per week, and he was on hydralazine nitrate combination. He was on beta blocker carvedilol 12.5 BID, spironolactone 25 milligram once daily. On examination, his blood pressure was in the range of 92/55, and his heart rate was 68. His GVB was 14, and he has clear both lung fields. He had S1, S2, and S3, no murmurs. He has bilateral pitting edema and scrotal edema. This is his ECG, showing white QRS complex with mainly left ventricular pacing, as evidenced by the right bundle branch block and the inferior axis. This is his labs and biomarkers. His probenine P was 9,300 picogram per ml. Troponin T was positive, 61 nanogram. Creatinine was 148 micromole. His NA was 132, and his K was 5. INR was 1.6 without any warfarin, and his hemoglobin was 13, albumin 37, and bilirubin 33. This is his X-ray showing huge cardiomegaly with the CRT in place, and as we can see, there is no much congestion in the X-ray. This is his liver, showed congestion of the hepatic veins, but there was no reported cirrhosis in his report. Echo showed dilated left ventricle, severe LV dysfunction. The RV looks also impaired. The left atrium looks dilated. The short axis view showing also the LV is dilated and impaired, severely impaired. The RV also looks impaired. The ejection fraction is so poor, reported as 10%. And the RV, as you can see, showed moderate severe impairment. TE was done to make sure about the amount of matter regurgitation. It was reported to be mild to moderate in the transthoracic report, and the Transesophageal confirmed is mild to moderate mitral regurgitation. Also, as you can see, severe RV impairment. 3D echo also confirmed the same results, severe LV and RV impairment without thrombi in the LV apex. We performed functional assessment of this patient. He had the cardiopulmonary stress test. He performed only 2 minutes. The peak heart rate was 132. Peak blood pressure was 102/71, and his peak VO2 was 10.1 ml per kg per minute, 41% of predicted. So this was the situation. So Dr. Lori, depending on your nice. Okay. Yeah.
So does the panel have any questions before we ask them?
Yeah, he didn't show us hemodynamic data.
Exactly right.
Yeah.
Yeah. Okay.
I want to see something else.
Okay. I put the hemodynamics at the end, but
You don't have to show it if you don't want to, but
yeah. I put the hemodynamics at the end, but if you want to see it now, his RA pressure was 14. His PA pressure was 62, 36, 42, and his BCWP was 22. His TBG was 20. His BVR was 4. His cardiac index was 1.7. MVO2 65%, and RV stroke work index 520.
Was any reversibility?
This is after reversibility, after dobutamine and Lasix.
Okay, nitric oxide was not good.
Yeah, no.
Okay. Any other further questions? I have a question, actually. I'm sorry. I saw this patient on hydralazine nitrates and spironolactone. This is, to me, a very weird combination with a creatinine of 148. I would have expected him to be on ACE inhibitors, ARBs, before going to hydralazine nitrates or spironolactone.
Yeah, this is an excellent question. So he was on hydralazine nitrate. He was maintained on hydralazine nitrate depending on his kidney profile, depending on the kidney function.
So by definition, he's not on optimal medical therapy.
Yeah.
Yes, Dr. Fah.
How long have you been following up in the clinic? How long has been followed up in the clinic?
He followed in the clinic between August 2014 till December 2014.
So what was his weight in August, and what was his weight in September, in December?
There was no much big improvement on medical therapy. There was no dramatic improvement in the weight change between August and December.
Has he required any inotropic support?
Yeah, he received inotropic support twice.
Twice?
Yes.
Before that, I want to ask Dr. Kashur and Dr. Tori, because both of you commented on the pulmonary hypertension. What do you think of this? Would you think of any interventions for that? Do you think this is prohibitive of anything? What's your interpretation of this hemodynamics?
I mean, first of all, this patient has significant pulmonary hypertension. You can see that the mean pulmonary arterial pressure is 42 millimeters of mercury. Although, I mean, the PVR here is actually misleading because likely this man is big because his cardiac index is 1.7. So just I calculated his PVRI, which is about 12 wood units per square meter, which is really very high. I mean, even in the area of congenital heart disease, those numbers basically indicate if it's a congenital heart disease with left right shunt, that patient will be deemed incorrectable. And if you correct them, usually they don't do very well, which means they have advanced pulmonary vascular pathology. There's some discrepancy between the cardiac index and his MVO2 because 65% lies in the kind of low normal range, and cardiac index of 1.7. So I mean, the hemodynamics indicate that there's significant pulmonary vascular disease, which basically, and if you take the cutoff of TPG of 16 millimeter of mercury, he's basically not candidate for transplant. His diastolic gradient is is actually 14, which is really very high. So again, this indicates that he has fixed, likely likely fixed, pulmonary hypertension mixed between, his wedge is high, so it's a mixed post-capillary and pre-capillary. He did not receive vasodilator therapy, so we don't know how much
But I
reversibility
think he
there.
did receive the butamine, right?
But
Dobutamine and
Dobutamine.
Lasix, yeah.
do we have hemodynamics after the vitamin?
These numbers are after the butamine, right?
Or this
Yeah.
are after?
Yeah, this after Dobutamine and Lasix.
So,
Yeah.
not very advanced, very advanced.
Dr. Torrey, did you want to make a comment?
Yes, yes. So I think appropriately, he's not a candidate today for heart transplantation. However, we have a couple of papers that document that patients like this one that are chronically unloaded, particularly with devices, but also in the past with heterotopic transplantation, what appears to be fixed pulmonary hypertension in this setting can be reversed over time. And the opportunity for this patient arises because it doesn't seem to have overt liver disease secondary to passive congestion, and the RV function, even though in the echo looks is dilated, at least is maintaining adequate hemodynamics. So I think that the opportunity for this patient is clear to have, under best circumstances, an LVAD for chronic unloading that may potentially lead to reversible pulmonary hypertension, making them a candidate for heart transplantation. So yes, at this point, cannot go straight to transplant, but I think he would be a good candidate for VAD or mechanical support therapy.
So I think the assessment in terms of does he have end stage, even though he's ambulatory recent, clearly yes. Is the intermax for rest shortness of breath, low blood pressure, albeit not on ACE, overt abnormal hemodynamics, congested liver. So this guy has end stage disease. He's intermax 4. One can argue he's going to be intermax 3 to maintain his hemodynamics on inotrope. So I agree. I mean, our institution, we would not proceed directly with heart transplant given the concern for post-transplant RV failure, but we would tailor the therapy, leave this one to try to understand what the pulmonary pressure would do with diuresis, maybe a balloon pump with ongoing inotrope. Unlikely. We too do nitric oxide testing to test for reversibility. So we would aggressively pursue all that. At our medical review board, the discussion would be, what's the likelihood of RV failure? The sicker you are going in, the higher the likelihood in general concepts. I was looking at your echo. We've reported out in Journal of Heart and Lung Transplant, RV remodeling out of proportion to LV remodeling in terms of size. First ones to report that were Kukuka and colleagues in Berlin, Germany. We do it by transthoracic, pre-transplant. That RV looked pretty generous. In fact, that RA atrium looked greater than your left atrium, but I was very reassured that your CVP to wedge relationship looked workable. We use the Cormo score. We've looked at that in terms of its accuracy to predict post-RV or need for RVAD at our institution. So I think a continuous flow LVAD, I think he's at higher risk for RVAD, but not preclusive, not on the vent. He's not that sick. He's not as sick compared to others we see. But he's going to need to have significant protection, intra-op, early post-op, in terms of RV protection.
You saw the RV stroke work index,
Yeah.
which is the relation between the pulmonary and the CVP. It was
It's above
520.
400. It's above 400.
Above 400. So it was hopefully
Hopefully okay, but still, like a guy
Yes.
like this, he would have intra-op nitric,
yeah.
very diligent, like I one with surgery in terms of avoiding bleeding, and we'd have a low threshold for temporary RVAD, not a bailout, but prophylactic, if you will. But I think we would get away with him and just commit to continuous flow LVAD.
So answering your first question, is he advanced? I think we all agree that he is advanced heart failure.
Yeah, but in terms of medical therapy, I see some. Do you think this man could be better on ACE, ARB? Could we try LCZ in this patient at this time?
What was his blood pressure again?
90s.
90s. So
Yeah.
I'll open it again. Dr. Yahya, what do you think about the role of ACE and ARB? He's diabetic. His creatinine is 148, potassium is 5, but he's on spironolactone also. So what do you think?
So first I have a question to Abdelfatah. Yes, he's beyond the stage of cardiac resynchronization therapy, but you have one already. So did you look at the percentage of pacing? Did you try to optimize the CRT? We didn't do it routinely, but in non-responder, we do consider it in some cases. And I agree with Waleed. The medical therapy, I'm not happy. I would start CRT before the aldactone, because aldactone, we don't use it with renal failure. If I decide not to use the the ACE inhibitor, I would not use the aldactone-2. If I would try to use one of them, it will be the ACE inhibitor rather than the aldactone.
So, Dr. Ostibi, you have some experience with LCZ. Answering Dr. Abdelfatah's question, what do you think about LCZ in this patient?
So I'm very concerned about his hypotension on this balance of medicine. I think he's past the point to derive a benefit, whether it's ACE or LCZ 696. I think the CRT question in terms of observation is intriguing, but from my perspective, I think he's declared himself now with end organ, and I wouldn't wait that several week of trying to play with the ACE. His vascular resistance is not super high. Like when we see patients with, systemic vascular resistance in excess of 2,000, maybe we'll vasodilate and try to get him out of that hemodynamic embarrassment. But I think his liver's already suffering. He has the pulmonary hypertension. That's a surrogate, like Dr. Torrey mentioned in his talk. So I think we can talk about the nuances of medical therapy in terms of what we could have done. But I think he's there. He has end-stage disease. He needs an end organ intervention, of which there's only one or two, LVAD or transplant. He's not a candidate for transplant. The only other question would be whether you'd offer syncardia, but I think we're all in agreement. His RV probably looks workable for isolated LVAD.
The BISTILE, the study that I quoted in my presentation, they looked at the mechanism because they want to know exactly why these patients, they do they do worse from beta blockers. And bucindolol actually has some vasodilator effect. So they looked at actually the placebo group because all of them, they are more than about 90% they are on ACE inhibitors or ARBs, plus digoxin plus diuretics. And they looked at whether similar trend is shown in those patients with placebo versus ACE inhibitors. And they showed the same, that people with ACE inhibitors, it's post-hoc analysis, of course, I don't know what to make out of it, but in these patients, they had worse prognosis. So I think when you have significant RV dysfunction, now you are moving from an LV phenotype to a complete RV phenotype, it seems that maybe all these medications that we are using, maybe they're not as effective and maybe they're detrimental. So reducing blood pressure in a patient with significant RV dysfunction, I think is not a good idea because RV is going to get worse. It's very sensitive to ischemia. And you really have to maintain central, a good mean arterial pressure to perfuse that RV, which is sick. So I think I don't think it's a good idea to use any other vasodilator therapy in these patients particularly.
Is there any role in using something directed for pulmonary hypertension, like sildenafil or short-term ionized milrinone, that could help this pulmonary artery pressure, preparing him for transplant or post-VAT? I know no one wants to answer that question.
No, I'll tell you what, I don't think we have data to support. There's one study from Mayo Clinic group, Berlin. They looked at the butamine in people with RV dysfunction. And that's actually a hemodynamic study comparing them with controls. And they showed that the butamine improves RV function because of its vasodilator therapy effect rather than they did a lot of really mechanistic analysis. And they showed that basically it's not because of inotropic effect, but because of its pulmonary vasodilator effect. And they showed that in those people with heart failure and RV dysfunction, the butamine has much more pulmonary vasodilator effect than in normal people. But I don't know what to make out of that. You cannot extrapolate that to sildenafil, for example, or other medication. I don't think there is a role for these medications.
Okay. So I have a question for Dr. Lori. The terminology advanced versus refractory versus end stage versus stage D, does this terminology make difference for you? You can use them the same way, or how you can use these terminologies?
To me?
Yeah.
Oh. Sorry. I think advanced may be less bad than refractory and end stage, but I'm not sure that there is a precise definition that helps us differentiate those. I think we refer to end stage when we clearly see there is no other alternative. We say refractory when patients are keep coming in and out and this refractory. Advanced is this group of patients that are not treated by the general cardiologist that we need to look for advanced therapy, somebody that you may be thinking transplant, VAD, maybe CRT. I think that's kind of the way I would look at those, but I'm not sure that there is a very precise definition. Does anybody, I don't know.
No, I mean, end stage equals stage D, right?
Yeah.
In terms of nomenclature. I think advanced is something we use for hospitalizations, concerns about that advanced stage C patient. I think when you enter end stage, I like just to keep it clean. End stage or stage D, advanced heart failure is a stage C, and there can be a spectrum of stage C patients.
But according to the ACC/HA guidelines, they are subset of patients with chronic heart failure who continue to progress and develop persistent symptoms despite maximally gradual medical therapy. And when we are thinking about advanced therapies, VADs or transplant, better to stay to say stage D or advanced. Once we move to end stage, means we have already exhausted also even the VAD or transplant. So maybe end stage, if those patients who are declined for VAD transplant, and advanced versus stage D for patients who may be eligible for VAD transplant, or I'm thinking about VAD transplant for those patients.
But if this patient, for instance, would not have pulmonary hypertension, if this patient would have had hemodynamics that were, say, a wedge of 16, mean PA pressure of 22, with a right atrial pressure of 8 and a cardiac index of 2, would you be defining this as end stage, or would you say this is refractory? And would that make any difference in your treatment options?
I think still I will consider him for transplant, despite this hemodynamics. Depending on the main problem which he has, which is the symptoms, as you said in your talk, symptom is the most important thing in defining those group. Advanced NEHA class, persistent advanced NEHA class is the most important thing in those group. Once the patient had 60 or 90 days of persistent NEHA class 3 and 4, he qualify himself as advanced heart failure, need specialized therapies.
Yeah. So I think in this case you gave us a very important signal, which is the pulmonary hypertension.
Yeah.
I think that as a reflection of the chronicity of the heart failure defines it as irreversible, i.e. end stage, in my opinion. So the idea of doing pharmacological therapy in this entity, when you already have an organ that's been injured in a definitive way, at least fixed pulmonary hypertension, I think it just defines them as a separate category.
Yeah. The ACC also gave more defined parameters to define those group, depending on the hospitalization, more than 2 hospitalization or ED visits in the last 1 year. NEHA class, deterioration in the kidney function is very detrimental. Weight loss without other cause, cardiac asphyxia. Intolerance to ACE inhibitors due to hypotension or worsening renal failure. Intolerance to beta blockers. Frequent systolic blood pressure less than 90. Persistent dyspnea and with dressing or bathing requiring rest. Inability to walk 1 block at the level ground due to dyspnea or fatigue. Recent need to escalate diuretics to maintain volume status, often reaching furosemide up to 160 milligram a day, which was typical in our patient, or to add supplemental metolazole. Progressive decline in serum sodium is very detrimental, and frequent ICD shocks. So it's very clear parameter, very clear factors, biomarkers, dyspnea status, blood pressure, hemodynamic blood status to define this group of patients. So we shouldn't, but the question now, should we integrate all of this or to have some of them? How much factors of this you need to define this group? Suppose I have one patient who is...
Is it and or one? Is one of these criteria enough to define a patient as end stage? I think one is enough.
Yes. Yeah, so for me, I don't think any one symptom or sign or finding, or whether it's biomarker, lab, or no one finding equals end-stage disease. It's if there's a constellation of things pointing in the same direction in terms of this patient has a more than 50% chance of dying in the next 12 months in keeping with end-stage heart failure, no matter what you can do. So I think the guidelines are in keeping with putting forth a full breadth of potential surrogates, and they're not committing this equals end stage on purpose to say this is advanced heart failure, many of which equal end stage disease. And so I think again, it's not a snapshot in time with the hemodynamics like what Dr. Torre mentioned. If that wedge had been a little high and index low with the same profile, I would still say this is end stage disease. This is a snapshot in time. They just did inotrope therapy, diuretics. And so I think, you know, with all the variables, and for me to keep it clean and with what we're teaching, at least in terms of an approach, I think it's if multiple signals are pointing that this patient has a high likelihood of dying, in keeping with what you've demonstrated, which is nice. It's a clean category for advanced heart failure, but at the end of the day, you have to commit is this. The ACC guidelines don't say end-stage disease is this, A, B, C. They don't commit. So they still give the clinicians that ability, and I think that's in keeping with Taylor. It's an individual patient. That art of say, okay, this patient does have end-stage disease, and I don't think they'll ever commit because can't be based on one or two parameters that you can prioritize in a clean way. So it could be challenging.
Just a philosophical question. Is end stage a pathophysiological mechanism related to heart failure, or it's our attitude toward the problem? So when the physician and the treating doctor and the patient is trying to consider transplant or an LVAD or any other modality of therapy, I would not call it end stage. But if the patient is not candidate for any of these, I probably would call it end stage. Do you agree with that, or?
My interpretation, end stage disease is an assessment that guides prognosis to where you are then going to consider treatment options, palliative care being one. So I use them as synonyms, to be very honest with you. I don't think, should influence the assessment. Okay. And I think you bring up a very good question. There's differences in what one may say, okay, this is end stage. You go to different institutions, say, we're going to optimize and tailor, and again, it's not, I wish it could be crystal clear in terms of being definitive. But what we do at our institutions, and much like I would imagine you guys do, you have the full medical review board looking at all these parameters, and it's up to the wisdom of the group to say, okay, we're all in agreement. This is an end-stage profile, and let's move forward. This patient's not a candidate for research. They've exhausted medicines, and we're talking in a concrete way about transplant or LVAD. It just allows for the working dynamic to be a better flow when we use that terminology and phrases. So I hope I answered your question. So we still offer palliative care for patients with end stage, but we offer VAD and transplant for patients with end stage. End stage equals stage D.
We decided to go ahead and we put for him LVAD, hardware, in December 2014. He's now 1 year after the implant.
Before you progress, allow me to ask Dr. Ghaffari, in such a patient, preparing him for the LVAD, how much would you, as a surgeon, be, how much would you go comfortable without an RVAD backup here or support? How much would you anticipate in such a patient that he would need some RV support?
Well, I think
we need to do a full evaluation for the patient, and with interview to him and his family, and evaluate his sitting at home, and discuss with him really the option of having an LVAD, and what does he expect post-op as far as comfort and as far as care for this patient. This patient is a good candidate for LVAD. The only take back is his RV dysfunction, but the only thing going for him is systolic PA pressure, which is high, that means the RV is really generating a high pressure. However, I will still entertain and explain to him in the consent form with his family, there is a potential need for an RV support post-op. It's still there, but it's something that he will declare himself right in the OR if he needs an RV support or not. He is not a perfect candidate for LVAD, but he will benefit from the LVAD, and if we leave him alone, I think he's going to go on a palliative pathway where he can't do anything for him, since he was declared from a transplant list. So yes, I will take him for an LVAD. The risk is not low, is moderate. The chance of RV support is there, but it's something I will not embark on it unless he declared himself in the OR that you cannot get him out of the OR without supporting his RV.
The patient improved clinically in terms of LV manifestations so much, no shortness of breath, no dyspnea, no orthopnea. He's doing perfectly well for a year, but still he's having the RV manifestation, he's having the edema, better than pre-op, but not resolved yet. So what do you think about next step for this patient?
So how, the question for that, how would you manage the RV post-VAD, even if you don't need the post-operative support? Is there anything much in medical therapy that we could help this patient with?
So I think there's a real phenotype of late RV failure in those patients that are at high risk, as we're talking about, that you can get through the surgery. And so we actually study these patients invasively with catheterization, those that are having residual smoldering heart failure, left and or right, to try to understand, is right-sided heart failure still secondary to left, or is it this predominant RV? So we have an algorithm where we correlate echo with actual hemodynamics. But if he's having significant RV failure, where he's having edema, needing to come into the hospital, he's having fatigue, it's affecting his quality of life, my bias is to tailor his therapy, meaning diuretics and pump speed, to echo and cath, where I'd want to know what his CVP is to his wedge, because if he has partial LV unloading on the pump speed you choose, you have to exclude occult hypertension. So I assume he has a mean of pressure that's under 90. Otherwise, that can precipitate everything, especially for the HVAD, which is so sensitive to afterload. So in a patient like that, I would have to be crystal clear about what his blood pressure is, invasive hemodynamics with concomitant echo, and tailor his pump speed to hemodynamic profile that's best to try to translate into maybe a better working environment for that RV moving forward. What would be concerning is if you did do that and his wedge is under 15 and his pulmonary pressure is normal and his right atrial pressure is 20, that's a guy I think is not going to do well long term. That's a more challenging scenario. We've had that in several where we have to commit to transplant. So in other words, if you reduce his pulmonary pressure and he's now transplant eligible but has smoldering RV failure, that's a perfect patient for transplant.
So you do recommend the right heart cath at this point to
Yeah.
assess his hemodynamics?
Yes, unless you have a good echo that you can rely on. What does that mean? If his left atrium is still the size of his basketball and his LV size is near his pre-LVAD LV size, then one could say you can maybe keep it easy and tailor his pump speed based on echo surrogates and still open his aortic valve to try to unload him more. But if you showed me a post-LVAD, if you were to show me a post-LVAD echo that left-sided surrogates looked unloaded with a smoldering RV, I would take him to the cath lab. So the easiest thing to do is to take him to the cath lab.
Do you have any post-VAD echoes?
I didn't bring a post-VAD echo, but the echo post-VAD almost the same dimensions, same parameters.
Did LV size reduce?
The LV size may be decreased slightly, but not that significantly, but the RV the same.
So we defined it by echo in a decrement of less than 0.6 centimeters. It was actually a fairly robust sign that you have partial LV loading that equates to a wedge greater than 15. So in other words, that LV should remodel something. It's pseudo remodeling, right? It's related to the LVAD being in place. So if it's the same, and you may not be unloading the patient ideally based upon pump speed, blood pressure, concomitant diuretics. These patients need concomitant medical therapy, many at least. That's a reality.
Yeah. Let me expand on this. I think that's a very important observation. The degree of unloading with these devices is not the same as you used to see with the old pulsatile devices. And there is no question that the phenomenon of pulmonary hypertension was much more powerfully reversed with pulsatile technique versus continuous flow devices. And so just the fact that you have a device today does not imply that you properly unloaded the patient, because you have to adjust, you have to tailor therapy, you do the echo-based hemodynamics or ramp the speed to really assess proper unloading. We did a study comparing in the past Novocor and HeartMate 1 versus micromed-Vakivat, and we determined precisely this phenomenon, the power to unload with pulsatile versus continuous flow devices, and it is a very clear demonstrable difference that's measured in hemodynamic change, volumes in the heart, and also histologically. So with these novel technologies, if you don't unload, it almost means that you're really not providing the patient with the objective, the evidence with the proper unloading. Therefore, you're not going to see the beneficial effect with mechanical support in terms of reversibility of PA pressures.
Should we look to other parameters other than the echo and other, for example, in the lab, in the biomarker stuff, could we find something that can help us to assess the improvement, or just depend on the echo and hemodynamics?
If you have RV failure, you need to be clear of whether it's secondary to residual left-sided heart failure or predominantly a right-sided phenotype in the setting of persistent fixed pulmonary hypertension. So there's no biomarker, hemodynamics, the gold standard. And we've done this now probably in about 75, 100 patients we don't stop the anticoagulation. We do a simple sonocyte, right heart cath. It's a non-issue, takes 15 minutes. So go for the gold standard.
Okay.
Any final comments? Would you consider this patient for transplant, depending on hemodynamics?
So that's a good question. How can you be reassured that pulmonary pressure is really truly down and not just influenced by the LVAD? So you need to do a ramp down study and try to take the pump as much as you can out of the equation. Use FIC and calculate your PVR. Look at your pulmonary diastolic pressure gradient to wedge. So if those were in keeping with criteria, namely PVR under 3, diastolic pressure gradient under 7, and a transpulmonary gradient that's under 15, I would get this patient to transplant as quick as I could. So I would take 30, we have the ability to take 30-day discretion to list them 1A to try to take advantage of that.
Yeah.
Yeah.
Any further comments? Or thank you very much, and thank you for staying until this time. We'll be back at 1:40, okay? Oh, thank you. Thanks so much. The discussion was great.
That's one.
Yeah.